My name is Anne Lanceley and I'm a senior lecturer in women's cancer and I work in the Department of Women's Cancer. I lead the Patient Care Research group, and our research investigates the experiences of women in health and illness with emphasis on quality of life and the role of caregivers, that's the self, family and professionals, in the health promotion, psychological response, palliation and survivorship. The research focuses on supporting, educating and working alongside women so that they're better prepared for the consequences of their cancer illness. Overall, we want to improve the quality of life of women who are diagnosed with cancer. We want to reduce suffering for them and help them. There are three main strands to our work. The first is diet, nutrition and lifestyle. The second is interventions for the relief and improved palliation of symptoms that arise either because of the cancer or because of its treatment. And the third is psychosexual recovery for women after they've had treatment. If I was to think of the single most important thing that the group has achieved, it would be the completion of a prospective randomised trial where we compared individual versus conventional medical follow-up for women after they've had their treatment for ovarian cancer. There was evidence for a quality of life benefit and patient satisfaction benefit for the individualised treatment arm. Delivered to protocol, the individualised follow-up by a nurse also resulted in a delay in the presentation of symptomatic relapse, and there were also cost benefits. With the nurse-led treatment coming out £700 cheaper than the standard treatment. This approach, this different model of follow-up care needs further validation in other studies, and if confirmed could make a very significant impact on the NHS. Our plans for the future? Well, we want to continue characterising weight and dietary changes after diagnosis, and we want to develop nutritional and weight maintenance interventions. A feasibility trial of diet and exercise interventions in womb cancer survivors is about to start. We know that women affected by gynecological cancer are often not aware of the sexual consequences of their cancer and its treatment. Most don't receive appropriate advice or help to recover sexual function, and the impact on their sexuality may be profound, both psychologically and physically. Despite this, there are treatments and interventions that can help women. We have funding for a feasibility trial to develop and evaluate a stepped system of psychosexual care based on careful assessment of individual needs. It starts with simple psychoeducational methods, moving on to more complex new talking treatments for difficult cases. And these are based on theories of how we treat loss and depression. Our pilot study of 100 women will assess the feasibility of conducting a full-scale investigation of the stepped therapy, and it'll indicate the potential benefits to the patients, their partners and also to the NHS. We also want to reduce by 50% the suffering of women caused by under-treatment of gastrointestinal symptoms in ovarian cancer. Our current work in this area will lead to a wider survey of gastrointestinal symptoms in order to design and test assessment tools and treatment algorithms for better palliation. A number of other projects explore the processes and benefits of different psychological therapies and heritage and art therapies. We'll develop these projects to better understand the role of these treatments in helping patients develop a sense of mastery, possession and control over their recovery. Over the last 3 or 4 years, the group is proud to have established a successful environment for PhD student research training, and we're really very keen to grow this further.